All right, good morning, everyone. Good morning. Welcome to the first ever NPDA Data Submission Workshop. First, I feel like I need to explain why I'm wearing this headset. It feels very awkward. It's going to take a while to get used to. But for the benefit of anyone who couldn't come today, either because of time or resource limitations, we're doing this as a live event in the RCPCH here today, but we've also got around 80 people joining us remotely through a webinar, and this is the best sound for them. If you're listening remotely, hopefully you can't hear too much in the background. The way we're going to manage this is sticking to times. There'll be people joining remotely for the different sections of the workshop today. So if they're joining us at a specific time, we need to start the session then. If you're listening remotely, you can send us questions. We've got Jamie at the back who'll be collecting them, and at the end of every session there'll be a Q&A where those questions will be presented, as well as any questions from the floor. So for everyone here, thank you so much for joining us today. So the idea for this workshop came from the annual conference that we did in January, and some of the clinicians there enjoyed the conference and thought that it would be really useful to expand participation in some of our events to members of the administration team or other people who are submitting data who don't necessarily have much of a background or a context of the National Pediatric Diabetes Audit. So to just get everyone increase the understanding of the audit, to enable people to share ideas between sites of how they successfully collect, collate and submit their data, and to do a bit of troubleshooting. Also, this is a brand new system that we've had developed. The college was re-awarded the contract to deliver the National Pediatric Audit this year. And our funders had some additional requirements that our old system couldn't handle. So it's a new system. We're a bit nervous about presenting it today because they were quite late to get the contract agreed and signed, so we couldn't start developing the system much later than we planned to in our original project plan. So we literally just took receipt of it, or finalized it, signed it off a couple of weeks ago. So we're still learning it ourselves. So we think we can probably answer all of the questions that you'll have for us, but be gentle. If not, we'll certainly find out the answers if we can't answer any today. So the program, we're going to do some background to the NPDA. I'm going to take you through our online reporting tool for anyone who's not had the opportunity to have a look at that yet. And then I'm going to take you through some key features of the system that you can use to check your data quality and accuracy. We'll take you through some other functionality, go through common queries, and then there'll be a workshop session for everyone here. So you can just tell each other, find out how other people are successfully collecting and submitting data, because we'd really like to collect some of that. Okay, sure. So the workshop session, we'd like to be able to produce a top tips for anyone submitting data. So we'd really like your help finding out how you successfully work with your colleagues to ensure an accurate and complete submission. So that's that. So just move on. Just trying to move on. Right, here we go. So the National Pediatric Diabetes Audit was established to compare the care and outcomes of all children and young people with diabetes receiving care from paediatric diabetes units in England and Wales. It's commissioned by the Health Quality Improvement Partnership, and it's funded by NHS England and the Welsh Government. We've managed it here at the Royal College of Psychiatrists since 2011, I think, but it's been operational since 2003. So we collect data from 100% of all paediatric diabetes units in England and Wales, who submit data from every single one of the patients under their care, from every single visit that those children and young people make. Children who are, also young people who are undergoing transition should still have their data submitted to the NPDA for as long as they remain under the management of a paediatrician. So far, the audit has been an annual retrospective audit. So data from the previous year, the previous financial year, from the 1st of April to the 31st of March is submitted to us, and we report on what happened that previous year. In addition to looking at the care processes and outcomes achieved by children and young people in the audit, we also offer patient-reported experience measures, PREMs, for parents and patients. And we receive data from the hospital episode statistics and PEDI databases. I'm sorry, I don't know that acronym. About diabetes-related hospital admissions of children and young people within the audit. And we put that data together with our own data submitted by paediatric diabetes units, and we report on that every 3 years, and I'll come to that in a minute. So the aims of the audit, there are several aims. The first one is we want to monitor the incidence and prevalence of all types of diabetes amongst children and young people receiving care from a paediatric diabetes unit in England and Wales. We need to establish the extent to which all the key care processes that children and young people with diabetes should be receiving, and enable benchmarking of performance against standards of care specified by NICE at a unit level, regional level, and national level, so we can track that over time and identify gaps in performance. We monitor national progress towards improved diabetes control, and we determine the prevalence and incidence of diabetes-related complications amongst children and young people with diabetes. So these graphs show how units are collecting our system. This data is from the last submission from 15-16, and as you can see, there are many different ways that units are collecting this data. So some units have an in-house bespoke database that they've had created for them. These unlucky ones have to do manual case note review, which I imagine takes a very long time. These ones we don't know about, and then the two most common systems are Twinkle and Diamond that are produced by HiCom. So the method that's used the most by units submitting data is CSV upload, and then there's 3% of our services. We've got 177, so I think that translates to, I can't do the maths because I'm nervous, but basically I think there's about 15 units submitting by questionnaire. Ooh, what have I done? Yeah, so we're frequently asked by units whether there's a system that we can recommend for collecting data for the NPDA, and there absolutely isn't. One, it would be inappropriate, and second, we just don't know what's good and what's not. We've got no experience of using these systems. It would be ideal, I think, from an audit perspective, and I think a lot of units have said it would be ideal if there was one national central system that could receive all the NPDA data or data from paediatric diabetes units. And that's certainly the system in place on the neonatal audit that Mel works on at the back. They all use the same system, and it does reduce the burden on units because it just gets sucked out, and it's consistent. It probably does help their data quality, but that's not where we're at now, and it's not our role on the NPDA to suggest any solution to that. I think it has to come from the networks themselves or units. So that's where we are with that. So it's a huge data set. Every single patient visit from every single patient in every single paediatric diabetes unit in England and Wales, we get about 126,000 lines of data after the data submission period. So it takes a very long time to clean that data and to code that data to get it into a point where we can start to do the analysis. So the cleaning involves addressing inconsistencies. We take one line per patient visit, and you would hope that the demographic information for each of those patients on all of those rows would be the same. It often isn't, so we have to resolve inconsistent date of birth, genders, this, that, and the other. And we're hoping that the new system is dramatically going to reduce these inconsistencies, so we have to do less at the cleaning stage and can get the results and the reports out quicker to you. So once we have cleaned and crunched all your data, we produce a core national report looking at the care processes and outcomes. Once that has been published, and that tends to be published around February or March every year, ideally, we are then able to send out or publish unit, regional, CCG and country breakdown of results. We try and get unit results out earlier than that, just to the units themselves. We can't make any data public until the core report has come out, but we try and give units an early view of their results. We use this data to present outlier information. I'll show you that on our reporting tool a little bit later on. And we produce a hospital admissions report combining unit submitted data and data from the HES and PEDI databases, which I spoke about earlier. And we produce this report every 3 years or so. The next report is coming out on the 13th of July, and I strongly recommend you have a look at it when it comes out, even if you just look at the key findings and recommendations, because there's some quite interesting and important findings in that report. And we also produce patient-reported experience measures reports for public view and for view by the individual units themselves. Okay. So once we put the data out there into the public arena, there's several different ways that that data is used. First of all, we hope that individual teams are looking at their data, identifying areas for improvement, identifying areas of success to celebrate within these reports, so that the data can be used to guide clinical priorities over the next year. We are required by our funders now to start communicating outlier status to units, medical directors and CEOs, just to let anyone know. We're talking about negative outliers here, but we would also like to be sending letters congratulating the positive outliers. So these units that have done really well or are a couple of standard deviations below the mean where they should be. I'll show you what I mean properly when I show you the online tool. Pediatric diabetes units in England receive best practice tariff funding for participating in the audit as well. And the CQC have asked us to provide data now to inform their dashboards for their inspections. So they can quickly look at a dashboard saying, based on their data on a couple of metrics. So they want to look at care process completion, and they want to look at HbA1c outcomes, and they want to be able to tell whether this clinic is doing better than other units, worse than other units, and whether they are improving or whatever the opposite of improving is. There's also plans for a quality measure to be displayed on NHS choices using NPDA data. We're going to eventually, we're concerned that people are going to be a bit confused by all these different quality measures coming out of essentially the same data. So we're going to, in the future, we're going to collect them all together once they're all in place and just see how they're being used. And if it is confusing to clinicians, if it's not helpful, we'll be advocating to scrap any of these. Probably not the CQC one, but we're not yet sure about the NH choice measure. But that's a whole other presentation. Have we got any network managers in here? Yes, we do. So we hope that network managers are using the data as well to look at performance in their local patches, and then hopefully provide support to units who are struggling a little bit. We also make the data available publicly through our website and on data.gov.uk. So we once it's published, it's out there basically, and anyone can see how your unit and your hospital is doing on these key measures. So this is a slide that I've borrowed from our clinical lead, Justin Warner. For anyone not too familiar with diabetes, HbA1c is an indicator of diabetes control, and children and young people come to clinic, they will have an HbA1c done as blood test, and ideally you want NICE recommend that all children and young people should be aiming for an HbA1c result 48 millimoles per mole or below. We're nowhere near that yet in England and Wales, but there is progress towards it. So here you can see the median HbA1c result in England and Wales in the first few years of the audit. And as you can see, it's fairly stable, it's a plateau, and it's way above where it should be, which will mean that children and young people with an HbA1c around this level are at increased risk of diabetes related complications. So it's not good news, and it's partly why we do this audit, why we are funded to do this audit. So I can show you what's been happening over the last few years, which is excellent news. That is a really great trajectory, and a lot of work has been happening nationally, in regions, and in units to keep bringing this down. So it's an incredible trajectory. Everyone's really proud of that, really pleased. But as you can see, we're still a little bit further away from that 48 millimoles per mole that NICE is telling us to aim towards. So there's work to be done. So we have a new contract for the NPDA, and as you can imagine, our funders are requiring more with the same resources, and they've got some other ideas, and we brought some other ideas. Our project board and stakeholders had some other ideas of what we should be doing with the audit to maximise its impact. So the first major thing is that we're moving from an annual retrospective audit to a prospective model. So from August, from the end of this data collection period, the data capture system will be set up so that you can enter data throughout the year and get immediate feedback on the data that you've entered. So this will be useful because one of the criticisms of the audit that we used to get was that by the time units have submitted that data, by the time we've cleaned it, crunched it, reported it, that data's out of date. So it's a benchmark, you know, it's real, it tracks progress, but it's out of date. And if units are doing things at a local level, if there are quality improvement activities going on that you want to see whether your outcomes are being affected by that, you need something a bit more immediate. So this new system, the one we've got at the moment has got some of the same functionality, but basically we've thrown a load of algorithms at it. So it will now calculate your unit's mean and median HbA1c. So every time you submit data, you'll get an update of what that mean and median is. So anything that you're doing at a local level, hopefully you can see the results of that much earlier on. We are also going to be doing spotlight audits. So these are little discrete pieces of work to complement the core report. So the focus of these, at the annual conference in January, we asked delegates to suggest priority areas that they think that we could cover additionally to the core data set. And then we discussed those with our dataset methodology group and the program board, and we came up with the idea of doing a workforce survey to replicate a survey of the workforce that was done by our colleagues at UCL a few years ago. And it was before tariff money came into effect in England. And the similar funding arrangements that came in Wales. So we want to see what the impact of that has been on units. We want to see who's working there, the headcount, in addition to just how the services are configured, what impact that has on outcomes. And that will be one thing that we are very aware of, is that participating in this audit does put a lot of pressure on units. There is an audit burden. This will be a very quick questionnaire that shouldn't even require anyone to do particularly any research. So it'll just be a desktop exercise, send in the results. The main work will be us in the office, crunching it, linking it with outcomes, this, that, and the other. So we're going to start with workforce probably next year. We're going to do a pump usage study as well. This is going to be in combination with the adult audit. So we'll be looking at outcomes pre and post transition onto a pump. We'll be looking at take up. We'll be looking at the demographics of people using and who have access to pump therapy. And additionally, I don't know if any of you were at the conference we did in January in Birmingham, and Ragnar Hannes spoke to us about what Swedish units did in order to bring their national median HbA1c crashing down as they did. And one of the things they did in Sweden was a quality improvement collaborative. That's what they credit with their incredible HbA1c results that they started to achieve now. So we had a bit of an underspend from the last audit, and we are negotiating with HQIP whether we can use this to fund a similar quality improvement collaborative amongst paediatric diabetes units in the UK. And we're also redeveloping the PREMS. The PREMS produce some really useful data, especially the qualitative comments that units could use to help inform improvements to their service before, but we found that there were some ceiling effects. So we needed to redevelop the questionnaires to make sure that they do differentiate between different units, especially because Ragnar was really excited about our PREMS when he saw the presentation at our conference. We're really ahead. No one else in the world, certainly not Europe, is doing pediatric diabetes PREMS. So we need to develop a tool that can be used across Europe so that we can have some comparative data. So that's in the works as well. Okay, so that's the end of that section. Do we have any questions in the room first? Hello. For the benefit of everyone at home, I'm just going to repeat the question, sorry. So the question was, how often are we going to do this prospective audit? And the answer is from April onwards. That's it now. So that is the model of data submission. You will be able to submit data all through the year. There'll be a cut-off point, obviously, at which that data will be downloaded, and then we'll crunch, analyze, and report it. But you'll have open access at all times to that system and be able to upload. Obviously, about 3 months towards the end of the audit year, we will be communicating to members and saying, please make sure you submit all the data from this financial year prior to this point, so that no one gets caught out. But yeah, it'll be open. Yeah, you can do it monthly. Yeah, you can do it whatever works. I think we'll see the first year. I think our funders are keen that we are encouraging units to submit at regular intervals, but I don't think we can be prescriptive at this point how often units should be entering data. I think we just need to see how the system is used, what works for different units, and then maybe at the end of the first year we'll produce some more guidance. But basically at this point it's 100% up to you, as long as all the data is there by the end of the year. And we would absolutely recommend you start entering data as soon as possible in order to identify any extraction issues or any data entry issues, so that they can be resolved quickly and your system tweaked to enable a complete extraction. Yeah. Mm-hmm. Mm-hmm. We don't do that. I mean, we discussed that at the dataset group, and I think the reason, I have to think back carefully about this. Sorry. So for everyone external, the question I was just asked was, prior to the college taking on the NPDA, there was a 15-month period where you could enter data from, so you could catch people either side of their annual review. I think the main reason is that the audit was set up to measure adherence to NICE guidance, and NICE guidance say you have to do these checks within a year. So we take 12 months. We take it very literally. We understand that there are some patients that are going to be missed either side of that, but at least it's consistent. So all services will have the same parameters for data collection. So in terms of benchmarking, that shouldn't affect. And we really do not expect that anyone will ever get 100% on any of the care process measures, and we're nowhere near 100% anyway. So that's why. And I know there's a few people that aren't happy with that, but the majority are. We can talk about that later, but I promise you, it has been discussed at great length in the data methodology group, and the decision was made. You know, it's an annual audit. Children should be having these within the same 12 months, and that's what we do. Mm-hmm. You got to draw the line somewhere, and everyone's in the same boat. Any questions from people at home? No questions. Okay, that's good. Any more? We've got 2 minutes until I have to do the next little bit for everyone remote. Well, I must have done a very thorough presentation. But before I start demonstrating, or we all start demonstrating different bits of the system, I just wanted to reassure you that if you get a bit lost, there is user guidance that you can look at home. We don't just expect everyone to leave here and be a genius at operating the system straight away. We are filming this or recording this webinar. It'll be on YouTube, and we will also be doing a YouTube tutorial on how to use the system as well. So don't worry if you miss a thing. And we'll also, me and Nayan and Mal will be around at lunch to answer any questions, and afterwards as well. And you can always call us or email us at the office as well. Okay, so it's just about 12 o'clock. So I think I can go on to the next bit. So, quick show of hands. Has anyone in this room used NPDA results online? Okay, well, I just have to apologise now to all of you, because this is going to be a bit tedious, but this is for the benefit of everyone else and anyone at home who has not seen it yet. So, we developed NPDA results online this year because prior to this system, we would disseminate unit results in a PDF, and that PDF would have comparative data in it, so you could check your unit performance against your local region performance, and you could look at it against the national average, but it wasn't interactive, and it's just a static document that was shareable but not particularly accessible externally. We loaded all the PDFs onto the system for anyone in the public that wanted to see, but it wasn't ideal. So we thought that one of the criticisms of our work here when Ragnar did his presentation was that we didn't enable benchmarking in quite the same level of detail as they did. They're a big fan of their caterpillar plots in Sweden, and they use that as a means of, chivvying on the people at the bottom to try and improve their position. He said you need to enhance the competitive element of this audit, go with caterpillar plots. And I wanted to put my hand up and say we're already doing that, but it wasn't appropriate. So here we go. We have built caterpillar plots into the system. The best way to access this system is just through the front page of our website. Our website links on everything, but if you just put NPDA into Google, it's the first thing that will come up. So this is the home page of the tool, and down here are all the options of things that you can look at. So if I start with annual reports, this is where you can download essentially the PDF that you would have received if we hadn't developed this system. So you can choose which audit year. So if I do 2015, 2016, and you can choose a specific unit. And then you can either download the whole thing as a PDF, or you can look at sections. So right now it's on the patient characteristics. And important to note, in this left-hand corner, the bottom left-hand corner, if you click on that, it gives you the option to either print the individual charts, download them in different formats. So if you've got a presentation that you need to make to your colleagues, hopefully this will be useful to you. And you can download it. You can download the data behind it as well. All of the data is available in a massive spreadsheet as well on the website, but there's a lot of data, so this might be an easier way of just getting of zeroing in on any particular data that you're interested in. So you can see here all these different tabs. We report at unit level, regional level, so there's the network data, and then for last year we were asked to present at CCG level, so that's now there as well. And all of these tabs have got the same options available next to them. So I'm going to focus on unit data. So you might be interested to know, let's see, how your adjusted HbA1c compares to other units in your region. So you've got a few options here. I'm going to choose Caterpillar. So maybe you are from Barnsley. These are random, by the way. I'm not picking on anyone in particular. And you might have someone that you've got a friendly rivalry with at Birmingham, so you might want to have a look at them as well. And let's look at 15, 16. And so let's see how everyone else in the same region is doing and the national average. So here you can see all of the units in the same region are coloured here, and when you hover on them you can see what their result was and the name. So here's Barnsley, here's me, and we seem to be bang on the national average, just about, so, or just under, so that's great, that's what we want. And our friend at Birmingham is slightly higher than us, so we can feel pleased about that. Okay, and then if I just show you that in a different chart, if I take national average out, oh, sorry. Let's see what that looks like. So all fairly similar, and again you can download that and print that off. This tab contains outlier data, and we define outliers as units who are 3 standard deviations outside of the mean performance, and I'll show you what that looks like. So let's look at this one. There are 4 metrics that we determine outlier status from. This one is percentage of young people aged 12 years and above who received all 7 care processes. So let's just pick on Barnsley again. See. and our friend down the road. And we'll look at all other units and all other units on the same network. So let's have a look at this chart. So along the bottom, we've got the number of children and young people in each unit. And up here, we've got the percentage of all young people in that, children and young people in that unit who received all of their care processes that you should have. The funnel plot takes into consideration the number of children and young people in that service. If you've got smaller numbers of children and young people, you're going to have greater variability than if you've got more. So a funnel plot takes that into account. Now, this line, see that? That is your 3 standard deviations line. This is 2 standard deviations, and this is the mean. So what you want, if we want all our children and young people, 100% of children and young people to have had all of their care processes, we'd want to be at 100% here. As I've explained, that's never going to happen. You only have to have one young child or young person to drop 1, and you get 0 points for that child. So if you multiply that, that's never going to happen. So all of these units, including the one that I've selected, including Barnsley, they have got results that mean that they are 3 standard deviations above the mean. That is very good news. So these are positive outliers. These are ones doing statistically much better on that metric than these units down here. As you can see though, there's a huge amount of variability on this metric. I think there are 63 outlying units, so that's a lot of letters. Just showing the variability. Others are a little bit different. So I look at adjusted mean HbA1c. We've got a much narrower distribution. So unit performance is much similar between. And this is an example of a graph, a funnel chart where you want to be down here because we want a lower HbA1c. So if you are an outlier below 3 standard deviations, that's cause for celebration. You can, it's quite difficult to see here, so you can zoom in by just doing that and reset when you want to have a look at it back there. Okay, I think that's a really good question, and thank you for asking it, because as I started talking, I realized I should have explained. So for anyone listening remotely, the question I've just been asked is, what does it mean? What does an adjusted HbA1c mean? So a patient's HbA1c is there's not objective value. They've had the test and they've got a value for that, and we call that the unadjusted HbA1c. And we know that there are some patient factors that mean that those patients are more likely to have a raised HbA1c, so poorer diabetes control. And the audit shows that girls, teenagers, certain ethnic groups, and people from more deprived areas have higher HbA1cs. So it's not really fair to compare units on that measure if we don't adjust those figures, because some units might be in a very deprived area, so they're likely to have an unadjusted mean or median that's going to be higher than their neighbour who's in a very affluent area. So in order to enable benchmarking, the data gets, I think they use a logistic regression to adjust the figures so it takes into account all the patient factors that we know impact HbA1c. So if you are from an affluent area with a predominantly male population, your adjusted score might be a bit higher. And if you are in a really poor area with loads of girls, loads of teenagers, your adjusted mean will be smaller, just to level the playing field when we're making comparisons between units. Thank you. Okay. All right, so Nayan, are you ready to do the next bit? Oh, perfect. Nayan's just, okay, ducked out. So Oh, a question from outside. Brilliant. Okay, so I've had a question here. So can we start entering data from April 2017 for the 17-18 data set? The quick answer to that is no. We thought it'd be very confusing having two systems running in parallel. So you should have started collecting the data from April 2017 from the new data set, but the system will only go live from August after this data collection has closed. Judith Reed asks, when data is being submitted by CSV, is the data retained or is it overwritten? Nayan's going to talk you through that in his presentation. Oh, this is a good question. Hussein Al-Safar asks, with this new commitment of submitting data frequently and prospectively, can we have a written recommendation from RCPCH as we need to convince our managers to allocate extra time for us to do so? I don't see why we can't do that. Yeah, we'll just put we can either send a letter out, a PDF. Oh, sorry, for Hussein, if you're listening to this, there was widespread approval for that. Was that right? Okay, widespread approval for that suggestion. So yes, there's something that we can do there for sure. Excellent. Okay, I'm now going. Oh, more questions. Okay, really quickly. Heather Carmichael asks, monthly upload, will this be for new data for the whole spreadsheet each time, thinking of the data overlap? Again, that's something that Nayan's going to cover in just a sec. Emma Davies asks, will a prospective audit allow the teams to see median, mean HbA1c results episodically only, or will it also show other information such as whether each care process is completed and for which individuals? It absolutely will do both, yes, and we'll demonstrate that in a sec. Lisa Goodman asks, can you explain again what the 3 standard deviations means? Oh, I was really worried someone's going to ask me that. So 3 standard deviations. It's a measure of variability. Goodness. So if I go back to the first chart, I think that'll help me explain better. Okay, so here we have all the results. They're very scattered. There's a lot of variance between them. So there's a big difference between the highest performing unit and all these ones who've got 0% of all their patients who've completed all their care processes. So there's a lot of variability, which means that the standard deviation, so that means the average space between each of these data points is quite high. Thank you. Yes, that's correct. Yeah, I think it's 99.8 at 3 standard deviations. Yeah. So 99.8% should fall within 3 standard deviations, and then that small percentage outside of that, you are an outlier. Basically, gosh, that was terrible. I'm so sorry. Thank you for your input. But basically, yeah, it's just a statistical measure of variance, and you want to be a positive outlier, so the other side of this line, but depending on the measure, you either want to be above it or below it. Speak to your clinical lead if you have any questions. Should be able to help. Okay, so I'm just going to hand over to Nayan now. He's going to talk you through the system.
Hi guys, so I'm just going to talk you through the new data capture system that we've developed. So last year we visited a unit in Leeds to see, how long does it take units to submit data and how much time they spend gathering this data. So we understand, it takes up quite a lot of your time. So hopefully we've developed a system that will save time to some extent in terms of the data completeness report and finding out which gaps in the data need to be filled in to give you, median HbA1c. But first things first, can I have a show of hands who's registered to the new system so far? Oh, very good. Okay, so for those of you at home or here who haven't yet registered to the system, as you know, we asked for Caldecott Guardian forms, and from units we asked for a contact form which would consist of the lead clinician and potentially 2 additional people who will be involved in submitting the data. So for those of you who've submitted that form, we've already uploaded your details onto the system, and the only thing you need to do is to enter your or set up a password. So how do you set up the password on the new system? So once you visit npda-audit.rcpch.ac.uk, you'll come to the terms of agreement, which you'll have to accept every time you log in. Then it's, if you are logging in for the first time or need to reset your password, click here. And your username on the new system will always be your email address that you've registered with us, so the NHS. So johnsmith@nhs.uk or something along these lines. So you enter your username here. So if I did mine, it's name.media. I'm allowed to have a non-NHS one because I'm an administrator. And then once I click email reset password, and then I go and log into my emails, which you will all see. A password reset that looks like this, and then I click on it, and then it will ask me to enter my email address, which is my username, and then set up a new password, and you're good to enter the new system. Now, the difficulty that we're having right now is after the cyber attack, obviously everybody's amped up the security, rightly so, on their systems, but what that's doing sometimes is preventing automated messages from systems that it should be receiving it from. So with some hospitals, we found that when we send the automated message to log in or for their password reset, it's being sent to either spam or being rejected altogether. So in this case, if you could ask your IT departments to please ensure that npda@rcpch.ac.uk is put on the safe list so that you can receive our lovely emails, then that would be appreciated. So for those of you that are not on the not down as the consultant or the 2 main submitters, you can still register for the system. You can go to the registration tab and fill in your details here, and this will come through to us. Now, if you're not on that list of 3 main submitters, we will go back to your clinical lead and ask them if they should be accepted onto the system. And if they approve, we'll approve your account and you're ready to go. The other option, if I log in, I'll show you, is that on this new system, those people who are registered are able to add people themselves. So you won't have all these. Obviously, I've got some administrative tabs. But if you go to user management, the user management tab, and you've got the right permissions as a site administrator, then you're able to add other people onto the system. So it's up to the units to ensure that they're adding the right people who need to have access to this data. So you click add new, and then username, you fill in the person's email address, then their full name, and then again, their email address that this needs to be sent to. Now, here I've got a list of all the units, but for those people who are registering others, you will have the units that you've got access to. So if it's Leeds, it will only be Leeds on there. If it's Bedford, it will only be Bedford on there. And then you can set the level of access that the person you're adding will have. So site administrator means you can add and remove users. You can submit the data. You can look at the data completeness report, and you can extract the data off the system, which I'll show you a little bit later. The next one is site user. You can do all those things except you can't add or remove users. And finally, for a site reader, they can only see the data completeness report. So you're setting their level of access. And then once you click insert, they'll appear on a list of users. And within a hospital, so say you've got 3 users, you'll be able to see who else is on there. And when they submit data, you'll be able to see who submitted yesterday or who submitted 3 days ago, and be able to track that essentially. So yeah, so that's the 3 ways of registering. So we haven't set a maximum, but for most units, we've got 1 lead clinician and then 2 others. But then, for example, if you've got a clinical audit facilitator, it's easier to manage if it's kept down to a minimum. So we haven't set a maximum, because even with clinical audit teams, there might be multiple people within there. So it's up to the site administrators to add those people and approve them. But if they come through to us, we'll check with the lead clinician, and then whenever the lead clinician gets back to us, we'll approve their account. Yeah. Is there any other questions on registration before I move on to CSV submission? For example, if you are part of multiple units, if you've already submitted your Caldecott and we know that you're part of multiple units, we've already registered you as such. And when you log in, you'll see that you're part of those multiple units. But if not, then let us know, and we'll add you on to submit from other units as well. Okay. So now for the majority of us, they'll be submitting via CSV. You want to go to the clinical and data import CSV. Now you'll see that this looks slightly different to the previous EWP system that we had. And the first thing that you'll see is ensure that the file name starts with the PZ code. Now everybody has a PZ code, and it's important here that the file that you submit, so say your PZ code is PZ123, then you put that as the first part of the CSV file's name. So if I show you some dummy files that we've prepared. So you want it something like this. PZ, well, we've got it as 000, but whatever yours is, and then you can put afterwards Bedrock Hospital or whatever. The reason that we have done this, one is security, to ensure that you only submit from the hospitals that you've got access to. And if you're submitting multiple CSVs or for multiple sites, we're able to track this. And if it's not put in that format, then the system will reject it. It won't populate the data completeness report. So it's better to format it like this. We already get questions from users that I've uploaded the data. Why is it not coming up in the data completeness report? So this is the main reason. So I'll go through that first bit. I'll select a dummy CSV submission. The next thing you'll see is test import. Now, this is something new that's there. Now, if you select the difference between test import and not test import, so if you select yes for test import, all that will happen is you'll get a data quality report. The data won't be uploaded onto the system, and it won't populate the data completeness report. Now, what is a data quality report and what is a data completeness report? Now, the data completeness report, which Holly will show you later, will show you which, for each of the type 1 patients, which care processes have been completed, which one are missing, and it'll work out the averages for your HbA1c and things like this. But the data quality report will look at which of your demographic information is missing. So for example, and also if you look through the other care processes, if you put, for example, a date for structured education, but you don't put whether they've had it, so you know when you select one and then yes, they've had the structure, so it will show you what's missing in your data essentially, but not which care processes have been carried out. So I'll show you an example like this. Yes, delete and start afresh. Import. My CSV is quite small, so it's uploading quite quickly, but obviously if you've got 300 patients, it can take a little while to load because it's calculating for the data completeness report in the background. So if you see here, like if you've put in a date outside the audit period, it will tell you. If you've put in postcodes, like incorrect postcodes or Scottish postcodes, it will let you know. You know, with BMI, if the weight and height don't match, it will let you know as well. Now, the question that people have that people might have is, can I download this error report? The answer is yes. You just click here on export to CSV, and you've got your data quality report. Now, on a normal submission, the next question, the next part of it, sorry, I keep saying question. So you've got it here, and you select no. So now when I upload this will stay on the system. It will be accessible to other people to extract this data who've got the relevant privileges, and you'll see a data completeness report as well. And the next thing is what to do with existing records. Now there's two options here. The majority of people will do delete and start afresh. So if I've submitted data and then I submit data again, whatever was previous will be overwritten, and this will now be on the system. You'll have access to all previous submissions as well, but when we run our extraction at the end of the audit, we'll take the last submission that you've done. So this is delete and start afresh. Update and append is if you've got a unit where multiple people are submitting CSVs, for example. So user one comes in and they submit 10 patients worth of data, then somebody else is in on another day and submits another 10 different 10 patients, then you can select update and append, and then when you go to your data completeness report, you'll see it for all those 20 patients. The system will take out duplicates. So if there's duplicate data, the data completeness report will take out the duplicates. Yeah? Do the submission ones here? Yeah, sorry. Yeah.
Okay, so we've had a question saying that the upload of data is such a pain that when we've got the prospective continuous data collection model, can units just still do an upload once a year? At the moment, we haven't, I don't think we're going to say, no, you can't do that. I think one of the reasons that prospective data collection has been welcomed, though, in a lot of units, is that it can spread the audit burden and make it so much easier just doing a little bit all the time. But it depends on what resources that you've got locally. If it's just one person and you literally just have to send it off yourself at different points, it probably would be easier if you did it at the end of the year, if that's how you prefer to manage your time. But what we would absolutely recommend is that you do a test at the beginning, halfway through the year, because we do really feel bad for units when you come to this quite pressured 2 or 3 month data submission period and you do your extraction and it doesn't look anything like what you were expecting it to. The year, so it's just not two months of pain, basically. Back to Nan.
Okay, so back to this. So I've already got my CSV uploaded and ready, and I've said that I don't want it to be a test and I want to delete and start afresh. So now I've uploaded this data, and again I'll get this error report. This error report is always available. So even previous ones you can check when you go into data extraction and you click open data error, and it will be available there for you for whenever you want to access it, really. Okay, so now that I've submitted that data, it will populate the data completeness report and then overview, and here we are. So the CSV I submitted obviously didn't do all the checks, but it was a dummy CSV. So now I'll show you for those people who will be submitting via questionnaire. So what you want to do if you're submitting via questionnaire is clinical and patient demographics. Now, where the system is different for questionnaire submitters is that you will have to fill in your demographic information for patients only once. And then once you filled in that demographic information, every subsequent time you add a visit date, it will already copy over. So if I show you an example, so Bedrock Hospital, you click on add record. Now, if I try and save it through questionnaire without filling in the relevant information, is a constant thing with the questionnaire, that it shows you the validation rules. So I'll put in an NHS number. And date of birth. And then try and save it, but it will still keep telling me which of the fields I need to enter. Right, now when I go back to the record management screen, patient will be there. And then now is when I can add the visit dates. So previously on questionnaire, you had to fill in the demographic information each time. So the demographic information will already be there. You put the visit date in, obviously during the audit period. But if I try and do it outside the audit period, it should tell me that it's outside, because the validation with the questionnaire happens inside the questionnaire. And then you can go through filling in the relevant information in each section. So you got filling in height. Now, obviously, if I put in too much height, it will tell me. And then tells me which fields I should fill in for each visit date. Now, the data that I fill in here will also fill in the data completeness report. So even for people who've submitted through questionnaires, we'll now have a data completeness report. Any questions on CSV or questionnaire submissions? So did you, when you submit the data, is it with 2 PZ codes? Okay, so and normally do you get 2 different reports when the data is analyzed, or do you get 1? You get 2. Okay, that's fine. So depending on the PZ code that you enter, that's the results that will go into the reports section. Yeah. So if you're getting 1 report, then combine into 1 CSV. And then if you're getting 2 reports, then separate them out into 2 CSVs, and you'll have access to both units to submit data. So when you submit for 1 unit, it will go into 1 CSV, and then when you submit the other CSV with the PZ code, it will go into the other. But if it's just 1 report you're getting, put it all in 1 CSV. Yeah.
Can you just we've had a question in the room about what to do if you've got 2 PZ codes, and I'm asking, is that because you've got 2 units that have merged? Yeah. Yeah. on our system. Okay, so for everyone at home, the question was, if you have two PZ codes and you're entering data from both of those, will data from one of those overwrite the other? And the answer is absolutely not. In the new system, data is attributed to the PZ code from the CSV that you've named and submitted. It's kept separate, stored separately, and there'll be different permissions depending on who's entered that data. I think it's also worth noting throughout the year or over the years, we have units combining, becoming like one team. And they might have a historical PZ code associated with, these two teams that have become one team. So we ask everyone submitting data to let us know before we start to analyze it, because the process for analyzing the data is, as I said, we clean it, we crunch it, we create all the results per patient, and then we allocate those patients to a unit and to a region and to a country. So if you have told us previously that your units are combining data, then that's we try and check, but basically once it's all gone into the pot, it takes us a long time to go back and reorder everything, especially because we're doing things like adjusting the HbA1c, and that's taking it's a nightmare. So we basically need to know what level are we reporting at, what is your unit, what merging or unmerging sometimes has happened in the last year locally. So hope that answers your question. Yeah, that's a good question. Thank you very much. I'm sorry, should have made that clear as well. So for everyone not here in the room, the question was, we keep talking about a new system. Are we talking about the system that people are going to be using to submit this 16-17 data? And that is what we're talking about. This is our new system. The previous system we referred to as the EWP, the electronic web portal, and yeah, there were some issues with it. I don't think it was a great system. Well, it worked, but we are more excited about this system. It can do a lot more. We've filled it with algorithms, and we're hoping it's a bit more intuitive. It's very new. We're still learning about it because a lot of the system, obviously, we specified ourselves following consultation with everyone who's going to be using it, but there's some functionality, and I'll demonstrate some of that a little bit later, that the company who developed this, who are audit software specialists, there's some functionality that they've just kind of chucked in as a added bonus, which we didn't even know to ask for. So we're still learning it ourselves. I mean, we know the basics, we know enough to tell you how to enter and correct and download and extract your data, but I think we'll have some work to do to ensure that our user guides and any like FAQs are really reflective of the types of questions that units are going to have. I mean, ideally we'd have had this system set up and running a month or two in advance of rollout, so that we could then go into detail with all the guides and get feedback on all of those. But it literally stopped being developed about 2 weeks. And well, they're still doing some minor tweaks to some of the cherry on top functionality. The basic stuff's done, the basic stuff's fine, but they're still doing stuff. So we had to produce everything really quickly. So we would really value any feedback you've got, anything that's not intuitive, anything that's not covered by the guides. Let us know. We'd be delighted and not at all offended if you wanted to let us know where there are gaps. Another question? Yeah.
So the question is that if there is more than one person submitting via CSV and the caseload is split, which buttons should be pressed when you're uploading the data? So if I go to the data import, so say you got user one and they've submitted 10 patients worth, and then they click delete. They click update. So if it's the first time, you're the first person submitting that data, then it's delete and start afresh. So you've got those 10 patients on the system. And then with the same PZ code, then your colleague submits the data for another 10 patients. And from then it's update and append. And then when you can track this on the data completeness report by which patients are coming up there. And then similarly, I'll show you the extraction in a second. You'll be able to see what each other have submitted as well when you can from the data extraction. I thought I'd just show quickly from the question that we had previously what happens when you're submitting for multiple sites. So this user should have access to 3 different sites. It's a test user. So when they go, so say they've got PZ 011 and 012, they'll upload it here, and then depending on the PZ code that they've got and the PZ code that's in their CSV, the system will read it and let you give you the relevant report. And then when you go to the data completeness report, only the ones that you've got will be populated. Yeah. Okay. Now I'll show you the data extraction. So if you've got, for example, people submitting multiple times or different users, or you want to see previous CSVs that have been submitted, you're able to download the ones that you've got the rights to. So you go to the data extraction on clinical and data extraction, and then you enter a password and then download. So it will download as a zip file. If you try and open that zip file, for security reasons, it won't allow you to open it straight away. You need, so for example, on this system, we've got 7-zip. So you need to find out which extraction tools you've got at your hospital to be able to access this data. So we've got 7-zip and extract files. And then I put the relevant password in, and then I'm able to access the data to see what has been previously submitted. Yeah. Sorry. Oh, we've got the in our user guides of how to extract the previous submitted data, but we have to put security functions in there so that people can't just extract the data. An example of a file. Okay, yeah. So some of the names of them are like 7-zip, WinRAR. They're just different extraction files, software, essentially. I've got the list of the names afterwards in for the troubleshooting and Q&A section. Yeah. So a lot of these will already be installed on your systems. Normally most systems have at least one extraction software. I guess if we haven't used it yet, but even myself, I didn't know it existed until I started to use it, and I was like, oh, okay, it's already there. For most files, there'll always be at least one already installed. Yeah. Okay. So I've shown registration, CSV, questionnaire, and extraction. Do we have any questions? Yeah. Oh, sorry. sorry, so when you extract the data from Twinkle, are you asking which patient should you put on? So yeah, so on the CSV file, we want all the patients that have had an appointment so from April 2016 throughout to March 2017. So all patients that have been seen throughout that period. So yeah, so on the data completeness report, it would be it won't show that patient because it would show that their date of diagnosis or date of leaving service was outside of the audit period, but it will still sit on that CSV. So for those patients that were, I guess, not supposed to be on that CSV, you would have to physically remove that. Or yeah, data cleaning.
For anyone at home or remote, the question was what happens to data that is outside of the audit period. So the system will highlight to you any data that's entered outside of the audit period, and it can either, I think it will still save though. So as part of our data cleaning, we will strip out any out of date range data, but we'd appreciate it if you could do everything that you can to just give us data from within the audit range. And your other question, do we want all patients, whether they left the service in the audit year or what types of diabetes? We literally want data from every single one of your patients with all kinds of diabetes, whether they left your service or not. If they left your service, it's really important that you put the date in so that they don't go into your denominator. So they don't count as one of the patients that we look at to see how many of their care processes they had over the year period. Because it's not fair to include patients who haven't had a full year of care within that calculation, because there's clearly a good reason why they won't have had their care processes completed. But we want to know that they existed at your unit, and we certainly, even if patients have died, moved on to adult services within the audit year, we still need their statistics for our prevalence and incidence and everything like that. So yeah, send us your data. Thank you.
So we've had two questions, one from Shakil Rahman. It says, please, can you remind us the exact dates for the data collection for this audit? So the appointments that we want are from April the 1st, 2016 to the 31st of March, 2017. And our data collection is open until the 8th of August. Yeah, so 8th of August, please don't ring us saying extension. So yeah, we've got that out there. One question that we've had from Manpreet is, can we upload more than once before the end? You can upload as many times as you want. There's no restriction there. As long as you've got the capability, feel free. Up until the last day of the audit, when we will extract the data. So Helen Cameron's question is, can a second inputter accidentally delete their colleague's input if they input by delete and start afresh? Now, we've tested with multiple users to an extent, so every possible avenue we haven't checked because there's so many potentialities with multiple users. But so for example, if I was to upload via CSV and then my colleague also done delete and start afresh, then for the purposes of the data completeness report, what was submitted last and then selected delete and start afresh will be on the data completeness report. On the system, we will have all the previous submissions that you've done throughout the submission period. And what we will extract is the final submission that sits on that CSV. So if you won't overwrite technically, because you can still retrieve that data that your colleague has submitted at any point. Right. So in the data extraction, Alison Darby has asked, by relevant password, do you enter your NPDA password? Now, when you go to data extraction, and in this section where you enter a password, no, you don't have to enter the one that you used to log in. It's any password that you choose to set up. It should be a minimum of 8 characters with at least 1 letter and 1 number, and that's it. So it doesn't have to be the one that you log in with. Yeah, so it's here. You just enter password here. Yeah, it could be the same. It could be the same password if you wanted. No, you don't set it up. No, it's just whichever password you choose to create here. Yeah, you just create any password that you want here. So this is all the previous submissions from different users. And it's a security. We implemented it as a security measure, so that you can't. If somebody had access to it and just click download, they wouldn't be able to just extract the data without knowing that password, the raw original data. So yeah, sorry. So if I'm getting the question correctly, is it to do with how many users you can have on the system, or to do with how many people? Mm-hmm. Yeah, so it's only those people that have been set up on the system. If you choose to add other people, they will also be able to submit the data with the relevant permissions.
Yeah, so for those people who are listening to this remotely, so we're just going back to the question in terms of why you need to put a password in order to extract your data on the system. This is because in terms of data governance, we have to be careful about where we extract the data with patient identifiable information. If it was anonymous data, then fair enough, you could just extract your data from the system and download it. But we're not sure where people are extracting the data and the environment they're in. So if it's a case of you're extracting data and it has patient identifiable information and people who should not be seeing that data has access to that file, then that is obviously a breach of data governance. So that's why we say put in a password, and at the other end you put in the same password and you can decrypt the file. Yeah. You can just put any password you want into this section here. So once you get to this page and you want to extract it, if you want to put in I don't know, butterfly 10, and then make sure you remember that password to extract it afterwards. If you want to share it with people that you know who's supposed to be able to see that data, then you can obviously share that password with them. But it's just a password. Yeah, if you want to. If you're happy to share and to allow them to have that password, then yes, you can.
Okay, and we've had another couple of questions come in remotely. So Heather Carmichael asks, monthly upload, will this be for new data for the whole spreadsheet each time, thinking of the data overlap? So it depends how you want to do it. You can just keep adding to the CSV that you submit and submit it every time, or you can just put new data in every time. The system will be able to recognize duplicates and will not count those patients twice. So it's really up to you, or you can just delete and start from scratch every time you upload. Emma Davis asks, will the prospective audit allow the teams to see median and mean HbA1c results episodically only, or will it also show other information such as whether each care process is completed and for which individuals? That's a great question. I wanted to talk about this one, partly in response to the gentleman's question at the back over there, because, well, the first part of the question, yes, it will calculate the mean and median for all HbA1c results for all patients within the system at any one time. You will also be able to see at a patient level who has had which healthcare checks. So say we're in month 9, and there's 3 months till the end of the data collection period, you'll be able to see which of your patients have yet to have which check. So as well as helping you to improve your data completeness and to target your efforts, we have to remember the whole point we're doing this, the whole point of this audit is not, we talk so much about data and getting the data right. The whole point of this is to try and encourage improvements to the care received by children and young people with diabetes, and to monitor and improve their outcomes. So we want to be able to show you at month 9, these are the patients that have not had their care processes for this year. These are the care processes that you need to provide to these particular children in order that they have had everything that they were entitled to and has been recommended by NICE. So we hope that it's, as well as improving data completeness, the main point is we hope that it enables units to provide better care, basically. And thank you, Lisa Goodman. Can you explain again what standard deviations mean? Brilliant. Yeah, thanks, Lisa. So, so standard deviation, it's an expression of variance within the certain sample. So I'm going to take you back to NPDA results online, and I'll show you again that funnel graph. Pick on Airedale this time. Okay, so this is the percentage of young people aged 12 years and older who received all 7 care processes in 2015-2016. This is the mean. This is 2 standard deviations above that mean, and this is 3 standard deviations above this mean. So you can see that this unit here has got a very similar result in terms of percentage of their patients receiving all key care processes to this unit here. But this unit here has got more patients in it. You get more variability in small samples, so it's not a fair comparison. So for example, if you flipped a coin 5 times, or sorry, 6 times to make it even, it's unlikely that you would get 3 heads and 3 tails, apparently. But if you flip a coin 500 times, 50% of those times it averages out. So you would get a head 50% of the time. So the funnel plot takes into account differences in sample sizes, and it takes into account that there will be more variability in smaller samples. So these lines show you where we can be, where there's differences that are statistically significant. So we can say that these services who are outside of 3 standard deviations, we can say with 99.8% surety that they are doing statistically better at ensuring their children and young people are receiving the care processes that they should be receiving. And we can say that these units, irrespective of their size, are doing statistically worse than their peers at 3 standard deviations. And there's another question about that, which I'm so delighted for, straight in front of me. Mm-hmm. Yeah.
And if it is 0.4 centile, that is your free standard deviation.
Mm-hmm.
This is at the bottom, and then on the top, it's saying on your 90. What's the top one? Is 99.6, and one is 99.8. So the 99.8 is the second. Sorry, your two standard deviation. So it's like a pedal.
Okay.
So therefore, at the extreme ends is your 0.4 and your 99.6. So this forms your three standard deviations, plus or minus.
Okay. For anyone not in the room, we've just had probably a better explanation for everyone in the room. So we think that this funnel plot hopefully is the best graphical representation of where you are at as a unit. But if it doesn't translate, we can do it in a different way. We had another question. Sorry, I don't have the piece of paper, so I can't remember whose name it was. Someone asked, considering the target is 48%, wouldn't it be more useful to, 48 millimoles per mole, shouldn't we show how many units or how many patients within each unit are achieving that? So if I take you back to the unit data, because so few children and young people are achieving the NICE recommended target of 48 millimoles per mole, we're not presenting that data yet. There are limits around reporting of small numbers because they make patients more identifiable. So where we're setting the bar, oh actually, gosh, we actually do, sorry, in our main report we still stick to 58 millimoles per mole because that's a more realistic lower bound. It's the previous guidance and we're sticking to it. One, so that we've got good comparative data throughout between each core national report. But on this you can see, so this is unadjusted. We only adjust data for the metrics that we benchmark against. So we benchmark, we want to know which units have got what proportion of their patients below 58 millimoles per mole and above 80. And because it's benchmarking, because it needs to be a level playing field, we do adjust those figures. But for this one, let's have a look at this. Let's do a caterpillar. Let's have a look. So see what kind of numbers we're looking at. All right, so there's some variability. So we go from some units have got no patients who are achieving that target. The national average is 6.5% of all patients achieving that target. But let's have a look at West Cumberland. 17% of their children and young people are achieving that target. So yeah. Okay, so now I'm going to take us back to the presentation and I'm going to show you oh, sorry, for anyone not in the room, Nayan is whispering at me and I can't hear him. Yes. Oh, yes, okay. Nayan's just going to upload some data so that I can show it in the data completeness report that we're just going to have a look at. Hold tight while we do that. Okay, are we good? All right, thank you. Thanks, Nayan. Okay, so let me just get back to where I was. data completeness. Okay, so the data completeness report, it's a feature of the system which we have developed, which hopefully enables you to identify gaps in your submission and to amend the CSV data accordingly. And it can help identify incorrectly coded data or data where there's a whole column missing. In order, for example, in order for a care process to be considered complete, when it comes to analysis, we usually want the result and we want a date next to it. So if you don't have a date next to that care process, we can't tell when that care process was completed. We don't know whether it was in the audit year, so that does not get entered into the analysis and you won't get credit for it if you haven't done it. Sorry, just pressed it by mistake. I've got lost. Sorry. Oh, I'm going up. Here we go. Apologies for that. That must have been really difficult for everyone's eyes coming in remotely. So it can also help you identify incorrectly coded data. After we produce reports every year, we get units saying, oh, you've got some of our patients on no insulin, and we don't really have any patients who aren't type 1s, so that's incorrect. And they hadn't noticed that their extraction had pulled through incorrectly coded data. So the data completeness report hopefully lets you identify any of these gaps or any missing demographic information, so you can kind of get a sense of your results as they will appear once the data has been cleaned and analysed and reported. There was a data completeness report on the previous system we used, but it didn't have any outcomes data. But now we have adapted it so that you can have an early look at results of care process completion measures and your HbA1c outcomes. And the clinical lead should view the data completeness report following final submission of data to assure themselves that the data is complete and accurate before signing it off. Many of you will be familiar with this form, but for anyone who's not, this is available on our website. As I said, our data set, it's a very rich data set. We're collecting a national data set. The quality of the data is really important because decisions are being made off the back of it locally, nationally, and international comparisons are being made. We want to ensure that the data is accurate and complete, so that the conclusions that we draw from it are correct. So we introduced this clinical lead sign-off form because we heard that in some cases submission for the audit was being delegated and not necessarily looked at by clinical leads, and then we get angry phone calls from clinical leads when the reports are published saying this doesn't bear any relation to my unit and the work that we do, and we say, well, I'm sorry, this is the data that your beleaguered staff have sent us. So this is to hopefully support you to get some extra eyes on your data. So upon final submission, please submit this form. Make sure, if there's been no input from your clinical lead, make sure that they've seen at least the data completeness report before they sign this off to say that their data is correct. Okay. Now, I'm nervous to demonstrate this bit to you because this got built and added to the system yesterday, so I haven't had too much time to figure out myself, but I'm gonna attempt it. So the new system has a query builder in it, which allows you to do your own interrogations of the data. The data completeness report does not do a full report on absolutely everything that you put into it. We just have the key things in the data completeness report that I'll show you in a second, but it's just the key things. If we put all the algorithms in it, it would have taken just months and months and months and months to complete. So it's just the basics, really. The query builder lets you interrogate your own data. You might not need to do this for this submission. You might not be interested. I think this will be more relevant when we have prospective data collection. And I'll show you why. If I just come out of here. So let's start with a data completeness report, actually. So this can be accessed via the clinical tab here. You should probably only have access to your own site. As an administrator, I've got all of them. So this is a fake hospital that we've just uploaded some data for. You can download this, print this off, put this on your clinical leads intro. Get them to have a look at it. And this is the front page, and it shows you your patient characteristics and some of their key demographics. This will help you identify whether we've got the correct denominators for your data. We've added treatment regimen on the front page because we found that this item had the greatest number of errors associated with it. So we put that there. So you can see if you've got like 50 of your patients on no insulin, you know that you've got an extraction error. So you can look at your data completeness on an individual patient level and for your site. So at the moment it's set to 7 key care processes. So you can see for all of these patients, you can see which ones of them have had all of their checks. And for some of these, you might not be so worried about if you see some X's here, but the patient left in the period, that patient is not going to go into your care process completion denominator. That won't be analysed and that won't contribute to your score. And what else have we got? Similarly, if they were diagnosed in the period, that patient will not go into your care process completion analysis, or if they died. And if they if the patient is younger than 12 years old at the start of the audit period, there are some key care processes that they aren't expected to have had. So maybe there's some younger patients here, and then you can see that these checks weren't applicable to those younger patients. So we've got 7 key care processes, and then we've got some additional ones here. So we're looking at patients who've had 4 or more HbA1cs in the audit period, what their smoking status was, or whether that was checked, whether they had a psychological assessment or structured education. And then you can see how many they had at an individual level. Comorbidities, I hate saying that word, comorbidities. We've got screening for celiac disease and thyroid disease that we've just started reporting. When the NICE guidance were updated, they took out celiac disease as one of the annual checks, and now we're reporting just at diagnosis whether someone was given a check for celiac disease if they had type 1 diabetes, since they often co-occur. The guidance, I think it was 20. Okay, the question from the Okay, we just had a question from the floor. How recently did we start reporting or collecting that data? Because at diagnosis, and we've always collected date of diagnosis. We've always collected dates of, yeah. The comment back was that we've only ever asked for data collected from annual review. That's a local interpretation, I'm afraid. We ask for all care process dates throughout the year. We let you know that only children and young people who've had a completed year of care will go into your denominator, and we hadn't realised the care process completion. We hadn't realised that meant that other tests were being submitted out of that time. So since we had the date of diagnosis and we had dates of care process completion, We then looked to see how many of the patients diagnosed within the audit year had received any of those, had received celiac and thyroid screening within 90 days, which was considered to be. Well, we have. Mixed response. Some people are saying you have. I mean, the guy, as far as I'm aware, we asked for details of all care processes completed throughout the whole year. We hadn't realised that what we're not reporting, people weren't submitted, and that's unfortunate. But going forward, I think we will. I think there was a caveat in the national report actually that we weren't sure about data quality since it was the first time it had been reported. But next year that won't be the case. So that's why we thought there wouldn't be any problems just cutting the data, analysing the data slightly differently in line with new NICE guidance. We did. Okay. I think what the query highlights is just local variation in ways that data is collected and submitted, which is something that we're very, very interested in ironing out. Thumbs up. Yeah. Good. Okay. I'm really sorry. I've got 5 minutes, I think, until lunch, and I want to show you this query builder before I do. So I'm just going to move on if that's okay. Sorry, I've shown you the individual values. I'm going to show you the site values now. So you can see just your overall site results, completeness requirements on this side. So patient level, site level. So the query builder is here. And I'm going to select my hospital. And so previously, when I was playing with this, when I was trying to teach myself the system, I set up this query. This is something that you'll see in your data completeness report anyway, so it's not particularly useful. So let's go with the number of children and young people with type 1 diabetes. And then that is set up. So at the moment, it's going to show me their NHS number and their gender, but maybe I want to see their date of birth as well, so I can add that to this query. So the query that I've done for number of children and young people with type 1 diabetes, I've gone into demographic data there, diabetes type, and then is equal to, but I could have, there's a list of options here, is equal to 1. So you'll need your dataset document to use this data query because each of the responses has got its own individual code. This button is an important button. It's, if you don't check this box, you'll receive information from every line of data entered. But if you just want to reduce it to patient level, you click that. We don't yet have any user guidance for this because it literally got built yesterday. So we'll be working hard to get that up on by next week. But I'm just so you can sort of see this functionality, because it is hidden a bit and you won't be looking for it because we've never had it before. So if I go to update results, it will show a maximum of 50 records on the screen. And so this is a fake NHS number for all the children and young people identified with type 1 diabetes and their date of birth, which I've asked for, and their gender. So I would refer back to the dataset document and I would see that these are male and these are female. And I might want to do some checking of that data or add some data to that, so I can export that in Excel. And then it'll give me a nice little chart. So maybe you've got so let's do one from scratch. Let's clear that. I could either save that query to run again for next time I upload more data, so I can see how that will go, but I won't. So if I clear all that, so let's do a new query, and let's do number of non-type 1 patients. And that's fairly self-explanatory, so I'll just copy that in there. This bit you can import. The query that I just did, I could have exported it and saved it as a file, which I could then send to a colleague if they wanted to run that particular query and didn't want to start from scratch. I mean, that was an easy query. It would be just as much effort to export it and send it as it would be to just tell them over the phone how to do it. But if you've got a very multi-layered query, it might be worth sending and exporting. Let's crack on with this one. So I'm not importing file. This is one I'm doing from scratch, and I want to view these patients. I want to know which types we've got, and I want to know what their date of births are, and I want to know what their NHS number is. And the query, their diabetes type, I want that. I don't want to contain a 1, because 1 is the value for type 1 diabetes. And I want patients only, patient level data only, and I've ticked that. So let's see what happens. So we can see I've got 2 patients here with these NHS numbers, with these date of births. And I think that's a type 2, and that's probably a monogenetic based on the dataset document. So that worked, which I'm delighted about. So yeah, I think as you can play with this. I'm not sure, it might help you in this current submission to answer any questions that the data completeness report doesn't, but I think it's going to be of greater use when you've got like your year's worth of data, so it's becoming like a registry and you can just quickly query it. Some of you might already have systems that you can run these types of queries from, but I do know that a lot of services are just working from manual case note review. Sorry? So, there's been a suggestion for all that you can just do it from your own database. Some units have got terrible, have just got really limited access to this type of data in one place. So we're really hoping that this is of benefit to them. Oh. Okay, I'll just repeat that for anyone at home. Apparently this is much better than running a Twinkle report. Not that we have any, I'm not going to get into it. Okay, so have we got any brief questions on the data completeness report or on the query builder? Hopefully not the latter before we break for lunch. Oh, I'm being asked to pull it down a bit. Oh, the last, so which ones? All of these. Okay, we've got several questions coming in remotely. I'm not going to have time to do them all, but any questions that I don't do now will respond via email so that you're not left hanging. Let's see. Could patients who have left in the audit year be shown in a different section on the DCR report so it's clear when we are checking data that they have left? I realise there is a yellow block side of these patients, but it would look cleaner if these patients were shown in a different part of the report. That's a good question. At the moment, that was not part of the specification, but we will be developing this system in between all iterations of the audit. So I think that's something that we can definitely take forward. So thank you for that. Stephanie Gill says for 2718, if we upload data monthly, then overwrite the report each month, what is contained in the report back to us? So the data completeness report reflects the most recent submission of data. So if that submission appended data that you've already put in before, that data completeness report will contain all of that data. If you deleted any existing data and put in a new file, it would just have what's in that new file. Okay. Do you get accrual of care processes? Is all the comparatives still going to be in one report at the end? Yes, so you will still get an annual report that will go directly into NPDA results online, and it does have more results than we feed back to you in the data completeness report. Otherwise, as I said, the system would have just taken ages, and it wouldn't necessarily be worth it because we do still need to clean some of this data. So it's as a guide, basically. Lisa House asks, where can we find the PZ code for the hospital? There is a list on there's a list of PZ codes. It's an Excel file. Is it in the data submission page? Yeah, on the website. Yeah, the 1617 data submission page on the website. Yeah. Let's see. Given that most units have little control over how the eye screening is run in their area, is there an argument that we should have a completion of 6 care processes, excluding retinopathy, in addition to the 7? That's come up before, and yes, there is an argument for that, and I think that is something that will be, I don't think it's been discussed yet at the dataset and methodology group formally, but I think that that's absolutely something that we will do. That's terrible. So we've had a comment just highlighting how difficult it is to get support from retinopathy services to submit the data, to share the data. Yeah, there is absolutely an argument for that. It's on one hand, it's a tricky one, because on one hand, you don't want units who are trying and doing the best that they can locally to get penalised for it. But then the other argument that I've had, and I'm not saying which one is correct, and it sounds like that in some instances you can bang on doors all day and not get anywhere, but other units have said our retinopathy scores were a disaster, which therefore meant that our CarePro scores were a disaster. Our medical director asked why our results were so bad. This provided leverage, and now we have a much improved relationship with the retinopathy department. So, but absolutely, the question was: is there an argument that we should report both? I think the public do need to know how many children and young people are receiving all of the 7 care processes. But is it a fair benchmark for services? Not sure. The service, the quality. But that's a good question from the room. Are we able to put pressure on retinopathy services? As I understand, there are many different, there's not a centralised retinopathy services there, it's regional. So I think it was looked into before, and there were so many different ones that it was considered to be too difficult. But if there are... That's an excellent suggestion. That's a really good idea. Thank you very much. We just had a suggestion that the mailing list could include the secondary care provider and have them named on the report. That's great. We've just had an example on the floor of how there is a direct link between the two services. Did I understand that? Yeah. Okay. All right. Thanks for all those questions. Any that we didn't get to time to answer that have come in remotely, as I said, we'll email you or we'll call you. But now it's lunch. So thank you so much for staying with us this morning. Thanks to everyone who's come in remotely. It must be really weird just watching slides. They can't see us, by the way. They can only see the screen and they can hear us. So it's yeah, it's a bit of a challenge for them. So thanks to anyone who's still there remotely. And we didn't think that many people were going to do it, so we didn't send you a feedback form because we thought it would just be like a few people sending us an email. But anyone who's chimed in remotely, we will send you a feedback form. We'd really like to be able to use this format to have more workshops, maybe practice-based workshops, because we have this resource, we have this building, we don't have any more money, and so we can't just have like conferences all the time. But this is quite a resource-light way of disseminating a lot of information to around the country at low cost. So we're hoping to be able to do it again. We'd like to do it better. So yeah, there are feedback forms in your packs, so please don't leave without filling one in, and especially everyone participating remotely. We haven't experienced what that's like. We can kind of get a sense of how well the day's going in the room, but we don't know what it's like to be you externally. So let us know. Right, thanks very much.